Hello, everyone. My name is Sarah Mundo, and I'm one of post-heart transplant admin assistants. Today, we're going to tell you why we are here. The reason is all programs have tremendous growth. We are pioneering new ways to serve all of our patients with transplant needs.
Hi, my name is Jackie Miranda. I'm post-transplant kidney assistant. And on the first day that we were at the workshop, we share our hopes and fears, and we have clutters of our hopes and fears we all have. And the ones that show outline, it's keep high level solutions, develop a room of change agents, but we have personal growth. Those are our hopes. Our fears were no common ground, things won't change, but we come in with no fear, always open to change. Thank you.
Hi everyone, this is Dalia from UCSD Liver Transplant Pre, and
my name is Cindy Sapien, and I do pre-heart as a pre-AA.
Cool. So you see all this? We're gonna go over it. This is what we do.
This is our current state. Our first thing is when we get a referral, we determine if it's internal or external. We make sure the patient is registered and we verify the information to have the most accurate. We place the order and then we open the episode of care. We create the episode of care and we populate our care team. We get patient ready and we create a order on Epic. Referral gets acknowledged. We send a letter to the referring through Epic. We notify our team, our RNs, our doctors about the new referral. We update status of the patient in the EOC for all our care team. And then we review patient and we review patient's records, determine referral acceptance. Patient is accepted, and then patient moves to the other phase where we gather more information for the patient's referral. After auth it's approved, it will fall into our work queue. We will call patient to let them know we're ready to move forward with the evaluation. We schedule the in-person clinic along with education consult and education classes. We reassign patient team as needed. We schedule Zoom appointments or in-person appointments for their education classes. After that's done, we request any additional records that the RN might need. We get patient ready for the in-person visit with the provider. After they are seen, patient now it's ready to move into the second phase of the evaluation process.
You want more? Because there is more. So once the patient gets to their initial consult visit, we move forward to evaluation phase. This is where we do more work. All the studies that patients may need, radiology, cardiology, IR, echoes, you name it, you guys know it. Mm-hmm. So this is where all the work starts for our patients' evaluation phase. We work along with financial coordinators because some of these patients do need off. Once we get all this, and I'm making it sound very easy, but you know there's a lot going on right here, a lot. So once we have all the studies, all the information, we prepare patient for selection. In selection, they either get approved, defer, or decline. If they get approved, they get waitlisted. Once they go into the waitlist world, they're there waiting for a transplant. Once they're waiting, we're still looking for records, we're getting lab works, radiology studies, there's a lot going on. Then they get the call and they get transplanted. So that's good.
Why is current state important to know when you're starting this process?
Why is it important? To follow process. And that's why we're here. There's a process right now that we pretty much do it, but not the same. So what we're trying to do here is to improve the process as a transplant team, not as liver, not as kidney, not as heart, not as lung, but as a team. And what's important is that we all have a say to improve this process and to understand it together.
Hi everyone, my name is Renee Sierra. I am fresh post-heart transplant assistant. And in this next phase, we get the notification that patient was transplanted. Patient is inpatient, and then the EOC gets updated with the new care team. After that, we get notifications from the inpatient bedside nurse. We'll either receive like secure chats, an email, letting us know that patient is going to be needing clinic visits. We check to see if appointments are available. Also, we request guidance from our care team, our TCs, to let us know when the patient needs to be scheduled, when they'll be, basically when they'll be discharged. We schedule patient for a post-clinic, make sure that we have all the orders. We schedule them also for all their testing, biopsies, echocardiograms, clinics. We track their process, call patients to remind them sometimes of their appointments. Also, I know some of the departments are also doing like calling for lab work. Also, let me see here, for the financial part of it, normally most of the patients have a 90-day global period authorization that we can work off of. Some insurances do give us longer, so we're able to schedule further down. And then we're always in touch with our financial coordinators just to make sure that everything is good to go and that we're able to schedule, that there's not going to be any issues with the patient coming in to be seen, and then there is an issue with authorization. Once the patient's scheduled and everything, we do send out, some of our departments send out letters, reminders just of appointments, also biopsies, like we send out the prep instructions, letters for them to know where to go, parking, basically all the information they need so that they're not lost with further appointments. Scanning into media or requesting records if we need to request records. And then basically just repeating the follow-ups with them as they need to be followed up. And then Parissa's going to take care of the other part of the long-term post.
Hi, I'm Parissa. I'm an AA for post-liver transplant. So after the fresh post phase, they're going to move to the long post. Depends on their health and how they're recovering. The provider will let us know how often we have to schedule them for follow-up within 3 months, 6 months, or for a year. And we have to make sure we have to auth for all these appointments because by that time the global auth is expired. We have to make sure we have the referral. And also patients are required to have lab works prior to the appointment. So we call the patients 2 weeks prior to the appointment to remind them they are scheduled for follow-up and they do need to get labs done. We usually ask them where is their preferred lab so we can track and keep eye on the results. We also double check the patient's lab orders to make sure we have all the required standing lab orders, nothing is expired, everything's being faxed out. And after the appointment, they will let us know if patient needs any exams, anything, any ultrasound imaging, anything needs to be done. We also track down patient labs different ways. So if the patient gets labs at UCSD, it's easy to locate it. Some of them, they get it at Sharp, Quest, Eisenhower, then we can have access to it through Care Everywhere. And some of the other lab locations, they will fax us. So we get a lot of fax regarding the long post patients. We also get a lot of faxes about medications refill, home health orders, physician orders. This is a non-stop process going on. And I think that's it. Then there is another phase that they are post-transplant patients, but it's a referral. So they've been transplanted at another location. They just transfer the care to us. When we get the referral, we gather the important information, the insurance, why they've been transferred, the referring provider. Then we route it to the management to make sure we're okay to proceed with it. In the meantime, we get the okay from the financial coordinator to make sure we are authorized to use the patient's insurance. We're contracted. If everything goes well, then we call the patient, do the registration, and complete their appointment. And then that's it.
Hello, everybody. I'm Barbie, one of the pre-team lung transplant assistants. During our process improvement workshop, we were given tools to help us identify problem areas. One tool we use is the idea forms. This form allows us to come up with ideas that need improvements. We, the transplant assistant pioneers, will be providing blank forms to our teams back in the office to share with you. So you guys can provide us with ideas that you feel need improvement to help us to better design a standard work process for the entire transplant team.
Hi, my name is Rosa. I'm with the pre-kidney department.
Hi, my name is Ray Khan. I'm with the Transplant Quality Program.
And we did a airplane simulation that walked us through manufacturing paper airplanes. First, teams were split up. People were idling, waiting for previous process to finish. Jobs were getting batches and folding papers and passing to material handlers to give to the next person. We saw process improvements were needed, identified bottlenecks as we implemented processes, improved through reorganization process, flow, and redeploying resources to make implements in process. And then, do you want to read?
During the exercise, during the first round, it was a little bit of chaos. We had 0 accepted products by our buyer. As we've seen the pictures, we've got people idling, sitting around. As we went through different iterations, we noticed where the bottlenecks were, as Rosa pointed out, and we discussed, and then we redeployed our resources. We reutilized some of our folks that we had. We were able to do inline quality inspections. We were able to reorganize our process line, so there was a better flow, and the processes was a lot cleaner. Round 1, I think we had 0 delivered planes. Round 2, one team went up to 12, and then round 3, we had over 20 delivered aircraft to the buyer. We also went down in manufacturing time, and we went down in quality defects. We noticed that we did have to work on a couple of other items, such as work in process, push versus pull. We realized batching wasn't the most efficient way for us in this process, which relates back to a lot of our processes that we have throughout our program. Sometimes we're waiting around to pull jobs or processes, or sometimes we're pushing those out. All right.
Hi, I'm Marianne. I'm with Pre-Kidney, and I'm going to go over an activity that we did. This is the fishbone activity. It's a fishbone diagram to identify possible causes of a problem. So in the fishbone diagram, it's broken into categories: material, measurement, environment, machine, method, and person, which all contributes to the problem. We agreed that it's basically no standard work process across all 4 organs. In a sticky, we wrote down causes that contributed to the problem. So, for example, there's 4 different managers, teamwork. And after ideas were shared, each team member was given 3 voting stickers to choose the issues we felt were the biggest causes of not having a standard work process. And the 4, or what we agreed most upon, was we work in silos, the workload isn't shared across teams, training isn't clear enough for the work, and a lack of understanding others' roles.
Okay. Hi, I'm Cindy. I'm one of the post-lung transplant AAs.
And I'm Krishna. I'm clinical nurse specialist for your transplant quality team.
And we went over our 5 whys, sometimes 7. This was to determine some of the problems that we have in our departments in transplant in general. And so we went over the problem of being the workload not shared across teams.
So, Cindy, why? Why is the workload not shared across the teams and programs?
Good question. So it's because one of the whys was because of lack of understanding of team roles.
But why is there a lack of understanding of the team roles?
Okay. Because there was no standardized training across the center.
Why is there no standardized training across the centers?
Some of them were because we didn't have central location, or even the growth of our transplant department was different.
Wow, why did our transplant center grow so big?
And one of it is maybe a different pace for growth for each program.
And why do we have a different pace for each program?
I guess we're all operating as distinct silos and transplant programs instead of coming together as one.
Why is that the case sometimes, or we operate in silos?
Different organization structures, different program managements, even change of managements or physicians or AP.
So asking why a lot of times helps us get to the root of the problem.
Of course, yes, and that's why we're here.
Hello, everyone. Joshua Liggett here, Quality Specialist, supporting every one of our programs. We recently had our standard pork exercise it's really broken up into 3 different rounds. The first one, we just give everyone a sheet of paper and say, draw us a pig. You have 40 seconds, make sure it fits my expectations. But I don't tell you what they are. And so we get very cute, adorable pig drawings. Not what I want. So we take it back. I clearly spell out the expectations for this pig. I prepare a list of instructions, and you have 40 seconds, and I'm going to tell you all the steps one by one by one by one by one. And we got a lot of these interesting pigs. This one, you'll see there are ears, there are feet. These feet are upside down, and there's a big question mark in the middle because at some point people drop off. They can't follow along. It doesn't make sense. And then we take it a step further. So we have those same steps, but we have them associated with examples showing this is where and this is how. Visual representations of the work so that we're addressing all different types of learning styles, but also just giving people a better sense of what the work should look like. And then at the end of it, we actually had very consistent pigs. Everyone was producing the same sort of pig, and everyone fit the expectations of our buyer, our pig farmer.
Okay, so this week here at RPIW for Transplant Assistant, we talked about tools in Epic that the transplant assistant use and how different tools can be used in different situations. Currently, we are using a lot of these tools, but we're not using them in a consistent manner. We might be doing the same task, but using different tools to complete them. So here this week, one of the things we did, for example, was do a Gemba walk. For example, one of the tools that is available in Epic is scheduling work queues. Not everyone uses scheduling work queues, although all transplant assistants schedule stuff. So we had someone show what a work queue is and how they use it, just so everyone can see what a work queue looks like. So we looked at tools such as work queues. We looked at tools such as using encounters. We looked at tools such as scanning, such as dot phrases, such as order sets. And really our goal coming out of this is not necessarily saying this one tool is only the one tool you're going to use for this task, but it's figuring out this is the task we need to use. What are the right tools to use to complete that task in the most efficient way, in a standard way, and in a way that everyone understands.
Hi, I'm Matt Glassman. I lead our Center for Transplantation call center and our liver transplant business development. I also provide programmatic support across all programs in the Center for Transplantation.
So throughout the week, we revisited the goals of kind of why we were here in terms of creating a resilient process for all of our transplant assistants across the Center for Transplantation. We wanted to identify those opportunities. And when we looked at our current state, we learned that a lot of what we have to do for our patients is similar. And so we also then learned, is just what happens is occasionally how we do it is different. And so from that, we learned that with these patients, we want to create a future state vision where we can also, in addition to aligning what we do, we also align how we do it together. And so we used our lean tools that we learned to go forward and look at a future state vision with really a couple great tenets in mind. One was that we wanted to make sure that whatever that work is, that we're able to pick it up, whoever it is, whether it's across the Center for Transplant, and provide that opportunity to continue to move that work forward, as well as create processes that mean that we're not going back and looking at work to see, do I need to check this, find out that there's no work that needs to be done, and then rechecking it 2 days later, but rather creating a process in our future state vision that lets us know when we need to move on to the next step or when that work needs to get done. One of the other really key tenets of our future state vision that we talked about was how can we make sure that we are documenting and including our stakeholders in what's really important. So creating a process where our key partners, like our transplant coordinators, are able to find the information they need and quickly get to the status of a patient without necessarily having to search, having to go into multiple places, or having to have multiple conversations with us. And being able to move that work forward. So we're really excited to take this vision that we've created and start putting it and figuring out how can we move forward.
Hello, everyone. My name is Ray Khan. I'm part of the Transplant Quality Group. We are here to discuss our implementation plan. What we did is we came up with certain topics and we split up into 3 work groups. Our first group was clinic schedule transplant. In here, we worked through and assessed the new clinic visits, the return transplant patients, evaluation, Zoom one-on-one classes, and how to schedule those. And part of this will be is looking at standard work, reorganizing it, and even renewing some of it. The next group we had was our task management group. From here, they worked on defining standard work for medical records, standard work for letters, processes that are shared across all the organs, but bringing them in, standardizing them, and making them all work for everyone. And then our third work group was evaluation and surveillance. Here, we looked at all the specialties. We looked at imaging. We looked at labs. How do we schedule those? How do we book those for our patients? And what the different nuances is between all the different teams and how we can bring them all together and make it one cohesive process.
Hello everyone, my name is Deepa Group. I am the Senior Director for Center for Transplantation. This week during the RPIW with our transplant assistants, what we learned was applying the lean methodology. Lean methodology, as you all know, it's maximizing the value of the people who do the job by eliminating the waste in the process. And the reason why we do it, to reduce the burnout rate. This week, the staff learned how to rebuild a new system that will help them so they can enjoy the work that they are doing.